the doctor is in, and today we're going to talk about physical diagnosis of the cardiovascular system, or we are going to learn how to assess the heart and its blood vessels. So the first thing that you need to understand when trying to learn about assessment is the surface or are the surface landmarks. So as we try to visualize the chest, we try to visualize the underlying structures. And the first thing that you need to know is that the most anterior cardiac surface is occupied by the right ventricle. And in this photo, it is outlined in black dotted lines. So as we can see here, class, the inferior border of the right ventricle lies at the level of the sternum and the xiphoid process, while the superior surface, it is being tapered inferiorly, forming now what we call the base of the heart. So here we see that the base of the heart is located at the level of the sternal angle, and this clinical term refers to the superior aspect of the heart that is located on the right and left second interspaces adjacent to the sternum. So what I want to try to emphasize here is that the heart, its apex is located inferiorly, while the base is located superiorly. This is different with that of the lungs, where the apex is located superiorly and the base is located at the inferior portion. All right. So here on the next slide, we see the left ventricle being outlined. So for the left ventricle, it is located at the left lateral margin of the heart. And we can see here the apex is located at the apex is located at the inferior portion, and it is a tapered inferior tip of the left ventricle. So this is identified when you do palpation of the precordium. This is called now your PMI, or point of maximum impulse. So it is located at the fifth intercostal space. So 1, 2, 3, 4, 5th. So this is where it is located. The fifth intercostal space, or medial to the left mid-clavicular line. So this is the clavicle. This is the mid-clavicular line. It is located on the medial, not on the lateral portion. So here is the point of maximum impulse. So you have to make sure that you understand the location of the PMI, because we always try to understand this. So now, take note, class, I've mentioned that the point of maximum impulse can be palpated, but this is not always the case. Sometimes it's not palpable, even if we have a healthy patient with a normal heart. So detection is affected by both the patient's body habitus, or the size, and also the position during examination. So if our patient is in a supine position, or the patient is lying down, the diameter of this point of maximum impulse may increase approximately 1 to 2.5 centimeters. And take note, class, we have some patients that the most prominent precordial impulse may not be here at the apex, okay, or it may not be on the left ventricle, just to emphasize. So these cases, such as chronic obstructive pulmonary disease patients, class, the PMI may be in the xiphoid or in the epigastric area. So why is this the case? So above the, this is due to right ventricular hypertrophy, or enlargement of the right ventricle of the heart. Now, class, above the heart lies our great vessels. So we have here the pulmonary artery, the aorta, and the superior and inferior vena cava, which drains blood to the right atrium. Okay, pasensya na kayo sa mga manok, class. I recorded this video early because I want to have all my energy in the morning. So here, I just want to share with you a possibility that the PMI is not located on the left side, but rather on the right side of the chest. So we call this condition situs inversus, or dextrocardia. Remember, when you say dextro, this means right, cardia pertains to the heart. So the heart is located on the right side. Therefore, if it's located on the right side, then the point of maximum impulse will also be seen on the right side of the heart. Now, a point of maximum impulse greater than 2.5 centimeters is evidence of left ventricular hypertrophy. So if the left ventricle increases in size, it's also congruent that the point of maximum impulse is also increased. So the displacement of the point of maximum impulse to the lateral of the midclavicular line. Remember, this is the midclavicular line, and I have mentioned earlier, it should be located medial to it. But if it is located lateral to it, say for example, this is displaced lateral to the midclavicular line of greater than 10 centimeters, then greater than 10 centimeters lateral to the midsternal line. So this is the midsternal line, and if it is located greater than 10 centimeters from that portion, then this is due to a left ventricular hypertrophy and also in ventricular dilation from myocardial infarction or heart failure. So the location of the point of maximum impulse is very important to assess because it will already give us a clue as to what pathologic disorders might have occurred or might have been diagnosed in the cardiovascular system. So now on the next slide, we're going to talk about the different blood vessels of the heart, the great vessels. So we have here the pulmonary artery, which bifurcates into a left and right branch, which now sends blood to both the left and right lungs. We now have the aorta, so we're visualizing the underlying structures. So it curves upward from the left ventricle at the level of this sternal angle. So now it will arch posteriorly and to the left, not to the right. It will arch posterior to the left and then downward. Now here we have the superior vena cava and the inferior vena cava at the medial border, which channels venous blood to the right atrium. So having known your anatomy and physiology of the heart, you will be able to understand or visualize better the underlying structures in the anterior chest wall. So we see here another picture. We'd like to emphasize here the different valves. We have here a tricuspid valve, so called because of the presence of 3 cusps, and a mitral valve with 2 cusps. So it's also known as your bicuspid valve. We also have, of course, the aortic valve. So nakikita natin here in the portion of the left ventricle, going out of the left ventricle. So this is the aortic valve exiting. This is where the blood exits to the aorta. And we have here the pulmonic valve, where it is located it is the exit point of the right ventricle going to the pulmonary artery. So what I want to emphasize here, class, is the heart sounds, or the S1 and S2, arise actually from vibrations emanating from the leaflets of these valves, the adjacent cardiac structures, and the blood flow. So we have to study carefully the opening of these valves and the closing of the atrioventricular and semilunar valves in relation to the events in the cardiac cycle. This is to improve our diagnostic accuracy as we auscultate the heart. All right. So here, we have to take note, class, that in most adults over the age of 40 years, the diastolic sounds of S3 and S4 are pathologic. Take note, if the diastolic sound of S3 and S4, if seen in a 40-year-old patient, they are considered pathologic and are correlated with heart failure and acute myocardial ischemia. Heart failure and acute myocardial ischemia. So in recent studies, an S3 corresponding to an abrupt deceleration of inflow across the mitral valve and an S4 to increase left ventricular and diastolic stiffness, which decreases compliance. So you can see here, class, even the sounds of the heart will let you know what are the possibilities of this pathologic diseases. So an S4 will mean that we have already a left ventricle that has stiffness. Therefore, there is also decreased compliance. So in our next slide, we can see here the discussion of the cardiovascular system on the events in the cardiac cycle. So we're going to talk about the events in the cardiac cycle. And for us to understand first, we have to know what systole means. So when we talk about systole, we're talking about contraction of the ventricles, not the atrium, okay? Contraction of the ventricles and not the atrium. While for a diastole, it is the relaxation of the ventricle. So we can see here in the y-axis, the pressure in millimeter mercury and the cardiac events in the cardiac cycle, systole and diastole, and what happens to the pressure. So take note, class, in a systole, in a period of ventricular contraction, there is increased left ventricular pressure curve. Okay, so it increases in pressure, while in the period of ventricular relaxation, we can see that the pressure decreases, but late in the diastole, ventricular pressure now rises slightly. So what does this connote? When it rises slightly, it means, class, this is during the inflow of blood from atrial contraction. Because the ventricle are relaxed, it means they are open for blood to fill. So this is the time that the atrium will contract, therefore filling blood in the ventricle. So that is the systole and diastole. Now, let's talk about the different heart sounds. The closure of the mitral valve, or also known as the bicuspid valve, causes or gives us the first heart sound. So when does the mitral valve close? So it closes when the ventricles will contract in order, when the left ventricle will contract in order to prevent blood from regurgitating or flowing back into the atrium. So we can see here, class, that after an atrial contraction, so we have here the diastole, mitral valve closes. So we have here the left atrial pressure decreases, while the left ventricular pressure will now start to rise because contraction of the ventricle will happen. Now, in order for the blood not to flow back to the right or to the left atrium rather, then the mitral valve should close as the left ventricular pressure increases during a contraction of the right ventricle. So S1 is for mitral valve closure. Now, normally, the maximal left ventricular pressure corresponds to the systolic blood pressure. So we can see here, this is the left ventricular pressure, and during contraction at its peak or maximum point, this is where we detect the systolic blood pressure when we're trying to assess the blood pressure of a patient. So the contraction of the ventricle. All right, now we talk about S2. So S2 now is correlated to the closure of the aortic valve, which is the second heart sound. Now, imagine when the aortic valves are closed, it means that the left ventricle is relaxed and will now allow blood to fill it. Now, this is the time that the mitral valve will open and the right atrium will contract, therefore filling blood into the right ventricle. And the closure of this aortic valve will then cause the S2 sound. So here we see the S2 sound being pointed at here, where in the left ventricular pressure goes down below now that of the aortic pressure. Pag bababa na yung left ventricular pressure, it means the left ventricle is now relaxing. The aortic valve will close, causing us or giving us the S2 sound. Okay, so Those are the sounds of the heart, S1 and S2. Now we talk about S3. So S3 here, it may arise from a rapid deceleration of the column of the blood against the ventricular wall, which occurs in children and young adults. So this is due to period of rapid ventricular filling. So there is rapid filling of the left and right ventricle. Therefore, it may cause S3. Another pathologic heart sound is what we call the S3 gallop. So pathologic change in ventricular compliance in older adults. So this is a pathologic change in ventricular compliance in older adults. So those are the different heart sounds. Now, what we need to understand now is the chest wall location and origin of the valve sounds and murmurs. So we have to know what are the origin of the valve sounds and the murmurs. So the chest location, take note, aging may affect this, but this picture is very important as it shows us the different chest wall location. Now, let's talk about the aortic valves first. The mnemonic for this is, it's like from an ape, A and P, ape, to letter T, man. So ape to man. So it just gives us an idea, a fast way for us to remember where these chest wall sounds are located. So the aortic valve will be auscultated at the right second interspace of the apex. So remember the apex of the heart. So on the right side, on the right second interspace is where we find the aortic valve. And sometimes, if we can see the blue circle or oblong shape structure here, this represents at what other areas can we hear the aortic valve, but most commonly it will be heard best at the right second interspace of the apex. The pulmonic valve, on the other hand, is also located on the second interspace or in the third interspace, but on the left side, and it is closer to the sternum as compared to that of the aortic valve. So it has also at higher or lower levels. So the yellow oblong structure here represents what other parts of the heart the pulmonic valve may be heard. The sound of the pulmonic valve may be heard. And we have here the tricuspid valve at or near the lower left sternal border. So we have the sternum and the lower left sternal border here, left sternal border, not on the right. On the left lower sternal border, we have the tricuspid valve. And of course, the mitral valve is around the cardiac apex. So it's very easy to find it because it is also the location of our point of maximum impulse. So PMI, letter M, mitral valve, that is also, we're going to find the sound of the mitral valve. So this is represented by the red oblong structure. So this is where you can hear best the mitral valve sound. Okay, so it's very important for us to understand that. Now, let's move on to the assessment of the health history, which are the most common symptoms that we can see in patient with cardiac disorder. Therefore, we have to understand, since part of assessment is knowing the health history, we have to discuss this one by one. So first class, these are the possible symptoms or signs that you will have to see. Starting off with chest pain. Take note, this is one of the most important or one of the symptoms that can be correlated with a cardiac disorder. So 1% of our primary care visits are actually shown in outpatient visits shows chest pain. So this is the most common symptom of coronary heart disease. And the coronary heart disease, take note, is the leading killer for both men and women. And chest pain should always be considered life-threatening diagnoses such as angina pectoris, myocardial infarction, or dissecting aortic aneurysm and pulmonary embolus. You know, class, when I learned about chest pain and how grave it might become, I have personally talked to my parents that they should not just ignore chest pain or the symptoms of chest pain. And if they have chest pain, they are directed to call me immediately. That's how serious it is. So we have to distinguish, class, cardiovascular causes from disorders of the pericardium or from the trachea, because it may also show chest pain. What else? From our bronchi and parietal pleura. It may also be gastric in origin, epigastric, and other extrathoracic causes in the neck, shoulder, gallbladder, and stomach. So it may be chest pain may be correlated to the cardiovascular, but not only cardiovascular, but it may also be correlated to pulmonary, to gastrointestinal cases, to chest wall and extrathoracic causes. So in men, class, the classic symptom of chest pain shown is exertional angina, while in women, particularly those over age 65 years old, are more likely to report atypical symptoms. So sa mga lalaki, exertional, when they do activities, they feel chest pain, but sometimes in women, this is atypical. Sometimes they may go unrecognized. They just may feel upper back pain or neck pain, or even sometimes jaw pain, shortness of breath, paroxysmal nocturnal dyspnea, or meaning at night they have difficulty of breathing, or sometimes atypical symptoms such as nausea, vomiting, and fatigue may be symptoms of chest pain in women. So you have to make a careful history and take note, class, inappropriate discharge of patients with chest pain occurs in about, or results in about 25% to 40%. So when you become doctors later on, do not immediately discharge, complain of chest pain just because you are already toxic. Okay? So the next thing that we need to understand is, we have to begin with open-ended questions such as, please tell me about any symptoms you might be having in your chest. And then let's elicit the 7 features of chest pain. So what are the seven features of chest pain? Number 1, we'll ask, does this occur during exertion? Does it only occur if you are moving? Okay, number 2, what kind of activities bring pain? Meaning, do you only have chest pain if you have extraneous activities or when you do heavy lifting, or do you already have chest pain even if while you're just sitting down and watching TV or lying down? Do you already have that chest pain? Number 3 feature is, how intense is the pain on a scale of 1 to 10? So we use the pain scale. So that's the 3rd feature that we're going to ask. We ask the patient to grade the pain, 10 being the highest or the most painful, 5 is of moderate pain, and 0 means no pain. Number 4 is, does it radiate into the neck, shoulder, back, or down your arm? So we now try to see radiation of pain. So if it radiates to your left shoulder, to your arm, to your forearm, and or it radiates elsewhere. So we have to ask that question as well. So tatanungin din natin, are there any associated symptoms like, do you have difficulty of breathing, shortness of breath, or sweating? Nagpapawisan ka ba? Do you have palpitations, fast beating of the heart, or even nausea? And last of the 7 features that you need to elicit is that you're going to ask if, does it ever wake you up at night? And what do you do to make it better? So those are the things that you have to take note, because later on you will understand what it means. And you will be able to correlate it with diseases. So the next thing that we need to assess are palpitations. We have to teach selected patients how to take serial measurements of their pulse rates in case they have further episodes. So take note, class, it emphasizes here selected patients has to be taught. Of course, we consider the age of the patient and the level of their understanding in order for us to teach them about palpitations. So what does palpitation mean? Simply, this is the unpleasant awareness of your heartbeat. Normally, do you ever feel your heartbeat when you are not sick or during a normal day? Sometimes we forget about it, right? We do not feel it. But when you become aware of it and it's an unpleasant situation because of how fast it is, we call that palpitations. I always have this class when I drink coffee. Even just 1 cup of coffee gives me palpitations. Ito na lang ang nakakapagpapalpitate sa akin, kape.
Malamig ang simoy ng hangin.
Okay, so I'm just kidding. So anyway, this may be related to anxiety of our, for example, a hyperthyroid patient. Palpitations do not necessarily mean heart disease because sometimes when we do cardiac exercises, for example, running, we will develop palpitations as cardiac exercises will really increase the beat of or the heart rate. And most serious dysrhythmias such as ventricular tachycardia often do not produce palpitations. So even if you have irregular heart rhythm such as VTAC or ventricular tachycardia, it does not give us palpitations. So we may ask the patient, have you ever experienced that you are aware of your heartbeat? So what is it like? How do you feel about it? Ask the patient to tap out the rhythm with a hand or a finger. So, for example, they may describe that to us by tapping their fingers. Was it fast or slow? Was it regular or irregular? So these are questions that we may ask. We also would have to ask, how long did it last? Did it last for an hour or just a few seconds? So, and if there was an episode of rapid heartbeats, did they start and stop suddenly or gradually? So, the pattern of it starting should also be asked. And for this group of symptoms, an ECG is indicated. So if there are palpitations, class, an ECG is indicated, so it should be ordered by the doctor. Next, another thing that you need to assess is the presence of shortness of breath. So dyspnea. This is defined as an uncomfortable awareness of breathing. So common patient concern is dyspnea. So it may mean cardiac or pulmonary disorders. So these symptoms of shortness of breath, we just don't correlate it immediately to pulmonary disorders. Rather, we also consider this as a sign of cardiovascular disorder. Orthopnea, on the other hand, this is also dyspnea, but it occurs when the patient is lying down or in a supine position. And when the patient sits down, this difficulty of breathing is improved. So we say this is not generally dyspnea, but orthopnea. So this is quantified by the number of pillows the patient uses in sleeping. So of course, when the patient is lying down flat on bed and there's difficulty of breathing, when we try to put 3 pillows and the breathing improves, so we can categorize this as orthopnea. Okay, next is what we call PND, which is the episodes of sudden dyspnea and orthopnea that awaken the patient from sleep. So what does PND stands for? We have paroxysmal nocturnal dyspnea. So nocturnal, meaning it occurs while the patient is asleep and it causes them to wake up at night. So usually 1 or 2 hours after going to bed, this occurs and prompting the patient to sit up or stand up, even stand up, just to have air. And there may be associated wheezing or coughing, and this episode usually subsides but may recur about the same time on subsequent nights. So can you just imagine waking up waking up because you are having shortness of breath? Yung feeling na siguro parang may sumasakal sa'yo. Baka ganun yung feeling. I haven't experienced it yet, but probably that's how it feels. Okay, next is what we have is swelling or edema. Now, swelling or edema is excessive fluid located in the interstitial space. So, nag-accumulate siya, it accumulates. And it can absorb up to 5 liters of fluid, accommodating up to a 10% weight gain before pitting edema appears. Take note, class, when pitting edema is already evident, it means the patient have had already gained more than 10% of their weight or up to 5 liters of fluid in the interstitial space. Okay. Now, what we need to do when we are trying to assess edema is to record daily monitoring or daily morning weights rather. So every morning with light clothes on, we have to monitor the weight of the patient because the edema may not be obvious until several liters of extra fluid have been accumulated. So since physically or upon assessment, we cannot appreciate the increasing number of edema, we have to weigh the patient because if the patient increases in weight, we can quantify the severity of the edema. So causes vary. For edema, causes vary from systemic to local. So we have to focus on the location. Is it on the lower extremity, upper extremity? Is it on the face? And if it's on the lower extremity, is it both of the extremity or just one extremity? So this is associated also with other symptoms. Have you had any swelling anywhere? Pwede ring allergic reaction may cause swelling, right? Angioedema around the eyes or in the mucous membrane. We always have to ask if there are even others because there are sites that may have swelling but it's not obvious. So we have to really ask the patient. So also the time when it occurs has to be verified. Is it worse in the morning or at night? And do your shoes get tight, especially in the afternoon? So these are the things that we need to take note about edema. Next is fainting or syncope. So this is also known as blacking out or the transient loss of consciousness followed by recovery. So we have to take note, class, that since this is the most common cause of cardiogenic, also called neutrally mediated vasodepressive syncope or vasovagal syncope. So neurocardiogenic is the most common cause. Neuro, so it pertains to the brain and the heart. So both the heart and the brains are the origin of this. And if cardiac origin siya, such as arrhythmias, this is only 20% of the case. So most common pa rin neurocardiogenic, and if it is solely cardiac in origin, it comprises only about 20%. Another thing that we need to take note, class, is the general conduct of examination. So now we start with the general conduct of examination, and then we'll talk about blood pressure monitoring and jugular venous pressure monitoring. So for the techniques of examination, first is you always have to greet and introduce yourself. So why am I even teaching you this, class, even though it's something that should already be obvious? Sometimes medical doctors, nurses, or midwives, they forget about this. And when you do not do this, the patients may feel violated of their privacy and also they might feel disrespected. So sometimes you just go to the patient and then, not without saying anything, you just start to take their blood pressure. What would you feel about it if you're the patient, right? So we have to emphasize this. You have always to greet and introduce yourself to the patient, and you have to inform them what type of test you're going to do. So especially if, for example, if you're doing a breast examination, you just not do the breast examination without telling your patient what you're going to do. Okay? So, but we're not doing breast examinations now. We're going to do blood pressure monitoring and other assessment of the cardiovascular system. Next is auscultation before inspection and then palpation. So, unlike in the other areas wherein we do the inspection first, and then the auscultation, percussion, then palpation, here, please take note, class, that for the cardiovascular system assessment, we always start with auscultation because we do not want to perform inspection, palpation, and percussion and then perform auscultation, because by that time, we may no longer be able to assess the rhythm or the rate of the heart properly, because we have already done other tests to it. It may affect the results of auscultation. Okay? So cardiac examination skills, we have to master the following. So we have to describe the chest wall anatomy. That's the first thing we did. Identify the key listening areas. So remember, ape to man. And then evaluate the jugular venous pulse. So we'll try to do this. The carotid upstroke and the presence or absence of carotid bruit. Palpate the described point of maximum impulse. So by now, you have to know where the PMI is located. Auscultate S1 and S2 in 6 positions from the base to the apex. So we'll try to understand this and then recognize the effect of the PR interval on the intensity of S1 and the physiologic and paradoxical splitting of S2. So yung mga heart sounds ito. Then we have to distinguish systolic and diastolic murmurs using the maneuvers needed and evaluate and interpret a paradoxical pulse. Okay, so we'll be discussing all about this in the next few slides. So this is at the fourth intercostal space at the level of the sternum, meaning the arm should be at the level of the heart. Third thing that you need